Hello, I am Dr. Ahmer Karimuddin, President of the Doctors of BC. I'm pleased to be here tonight with my colleagues to provide you with an overview of expansion of the LFP payment model. It's particularly exciting that we're sharing this information with you on the first anniversary of the launch of the LFP payment model.
Hi, I'm Dr. Josh Greggain, the past president of Doctors of BC. I'm also privileged to be part of the team of physicians and healthcare leaders that developed the LFP payment model. I'll be speaking to some of the context around how we got here and what this expansion means for you and ultimately your patients.
Hi, I'm Dr. Tahmeena Ali. I'm the current president of BC Family Doctors. It's been the professional highlight of my career to be involved in the team that has developed the expansion of the model, along with staff from BC Family Doctors, colleagues from the Doctors of BC, and of course, our partners at the BC Ministry of Health. I will be speaking to some of the details of what will be taking place in the coming months as we roll out a comprehensive payment model across clinical settings.
Doctors of BC acknowledges that we work on the traditional, ancestral, and unceded territories of many different Indigenous nations throughout British Columbia. Acknowledging that we are on the traditional territories of First Nations communities is an expression of cultural humility and involves recognizing our duty and desire to support the provision of culturally safe care to First Nations, Inuit, and Métis people living in British Columbia. Let's quickly have a look at what's on the agenda tonight. We will start by recapping the highlights of the LFP payment model and the journey to incorporate facility-based care into this payment model. We will share more specific information about LFP facility-based care, including who is eligible, how it will work, and an overview of each of the 4 facility-based settings: inpatient care, maternity care in hospital, long-term care, and palliative care facilities. Lastly, we'll provide you the timeline of what you can expect in the coming weeks.
We all know the crisis in family medicine intensified during the pandemic. By 2022, nearly 1 million British Columbians were without a family doctor, and more family doctors giving up their practices every day. Together with grassroots advocacy efforts by patients and physicians alike, the Doctors of BC, BC Family Doctors, and the BC Ministry of Health came together to find a way to make family practice more sustainable so that we could attract and retain family physicians providing longitudinal patient care. Our collective work and our collective actions created a window of opportunity that brought us to launch the LFP payment model in February of 2023, but 1 year ago, which represented a major shift in the way family physicians were paid. Over the last year, more than 4,000 physicians have enrolled in the payment model, and we're starting to see for the first time in a long time hope for the future of primary care. The foundation of the model was created based on what you told us you needed to make family medicine more sustainable and ultimately rewarding, to value spending time with your patients, to ensure physician autonomy and choice, increasing family physician compensation, addressing the rising business costs, pay for time spent on indirect care or administration, and recognizing the complexity of care. You spoke and we listened. The LFP does not, however, stand alone. It is a step, a foundational building block in our journey to strengthen family medicine. Other important pieces of work being done include strengthening the physician voice and influencing primary care networks, enabling team-based care, relieving the burdens of practice through the after-hours care program, and building a coordinated locum program. Digital health and integration improvements continues to be at the forefront of the how that is to be accomplished. Through the provincial attachment system, we will have data to help us understand the system and to measure our progress. The divisions of family practice continue to play a key role in helping us understand and address local challenges, gaps in care to support physician practices and influence primary care delivery in their own community. Together, these building blocks can truly transform primary care and build a strong, sustainable foundation for the future. Due to the urgency of the crisis, the LFP model focused on care provided via clinics and home visits at the initial launch. We could not wait for all of the planning for facility-based care was completed, as time was of the essence and physicians and patients needed the care. However, immediately after the launch for the clinic-based elements, you told us the payment model needed some improvements, some adaptations. And based on your feedback, we made the following changes. We created the ability for locums to bill, not just for LFP enrolled physicians, but for longitudinal physicians in other payment models. We added a transition period for physicians providing care to patients who were not on their panel. We created a mechanism to identify your in-panel patients, which ultimately will be reflected in your panel payment. And we enabled billing at maternity clinics in addition to the LFP clinics, in part to address the crisis in maternity care in the province. In the same way that your feedback has led to ongoing improvements and refinements on the LFP models for clinic-based services, we will be looking to you in your clinics, in your communities, in your divisions for feedback on how the expanded model is achieving the goal of a comprehensive payment model, which supports you in the service that you provide across the facility-based settings. As we committed to you from the start, we also set to work on determining how to incorporate facility-based care. A short-term measure was to ensure continuity in our hospitals and long-term care, and FPFC then announced a $29 million in stabilization funds in the areas of inpatient care, maternity care, and long-term care. This took place in May of last year. Throughout the time since the start of the LFP journey, we have been actively consulting with physician experts and continued in regular discussions with the provincial government to incorporate 4 areas of facility-based care into the payment model. The creation of the LFP payment model has been and continues to be a journey with the goal of building a stronger primary care system. We know that family doctors provide care in a multitude of settings, as we are comprehensive physicians with a generalist and broad scope of practice. This includes care of patients throughout their lives, from newborn till end of life, care across clinical settings, the clinic, the hospital, the long-term care facility, the hospices, the home visits, and a multitude of other care across the variety of geographies in this province, including metro, urban, rural, and remote. As a result, this is designed as a comprehensive payment model across clinic and now facility-based settings. It is not 2 separate payment models, one for clinic and one for facility. It truly is a comprehensive payment model that reflects the comprehensive care that family physicians in British Columbia provide.
Now, let's get into what all of you guys are really here for. Some of the details of how the LFP payment model will work for facility-based care. Soon, longitudinal family physicians will be able to bill under the LFP payment model for care provided in the current settings, which include longitudinal family physician clinics, maternity clinics, and home visits, and it will be expanded to maternity care and hospital, inpatient care, long-term care facilities, and palliative care facilities. Now, to be eligible, you must be a family physician who provides clinic-based longitudinal care to a panel of patients. And of course, for facility-based care, you must also provide care in at least one facility, whether that is maternity care in a hospital, inpatient care, long-term care, or care in a facility, a palliative care facility. We recognize that there are very important family doctors providing the needed care in hospitals and facilities around the province who currently do not provide clinic-based longitudinal care. That's why we are working on supports for doctors who are not eligible for the LFP payment model. Some key elements included in the facility care-based model are similar to what you would have seen in the LFP in the current clinic-based model, and we've adjusted for how care is delivered in each facility setting. Some of this is going to be familiar, and it's going to include the 3 key elements for facility-based care as well: time codes, interaction codes, and of course, for our hardworking rural colleagues, the Rural Retention Program Premium. will be familiar to you from the clinic-based services under the LFP payment model, because we recognize that some things we hit out of the park, and we're going to continue those into this portion of the model. And again, I'm going to stress, rural retention premiums continue to apply to all time and interaction codes in this payment model. Some key elements of the codes, as well as the on-call payments. And on-call payments, I think all of you will recognize, is something that family physicians asked for many, many years. These on-call availability payments are not part of the LFP payment model itself, though they were designed with an understanding of how the LFP payment model's time and interaction codes will work for facility-based care. The payments recognize that the necessity and challenge of having a physician be available for 24/7 care to respond to the care and needs of patients in labor and delivery wards, hospitals, long-term care, and hospices is essential. And that lost opportunity cost needs to be recognized. For maternity care, the on-call availability payment is funded and provided through the Medical On-Call Availability Program, familiar to many of us as MOCAP. For other areas of care, the on-call availability payments are funded and governed by FPSC. This will be an evolution of the FPSC's current initiatives in facility-based care. We will provide some more details about the on-call availability payments later in this presentation. Daytime compensation for facility-based care is equitable with overall clinic-based LFP compensation. And compensation also considers how other physicians are paid for similar work. We kept the principles of simplicity front of mind because we've all heard resoundingly that the simplicity of LFP was a huge gain for all family physicians. The time codes. These will look familiar to you. We haven't changed what's been working, but there is a newcomer on the block. Direct patient care, indirect patient care, clinical administration on our newbie travel time. Travel time currently is part of indirect patient care time. It will become a new time code for both clinic-based and facility-based care. This will make it easier for you to bill and easier for all to understand and track how much time physicians spend traveling between clinics and facilities. The next few slides are going to talk about the rates of the individual time codes. Again, something I'm sure you guys are all very excited to see. So again, this is going to look familiar. The hourly time rate for the three codes, indirect care, clinical administration, and travel time, is the same for both clinic and facility-based settings, $130 per hour. Now, in regards to some of the different settings, they're going to be a little bit different depending on how care is provided in each setting. As you know, there are significant differences between how we provide maternity care, labor and birth care, inpatient care, long-term care, and hospice and palliative care. For many of us, the gray hairs on our head come from the time we spent on maternity care wards. Each varies in acuity, staffing, unpredictability, as well as the proportions of scheduled and unscheduled care. For indirect and long-term and palliative care in facilities, the direct patient time will be paid at $170 an hour with a higher interaction code. And for maternity care, direct care will be paid at $230 an hour with lower interaction codes. And that reflects, again, the unpredictability of labor and birth care from primips to multips, fast births to slow births, uncomplicated labors, and the highly complex ones which age you in minutes. In all circumstances, daytime compensation for facility-based care is equitable with average clinic-based compensation under the current LFP payment model. The time codes. We have to recognize that direct patient care in facilities is provided all the time, whether it's on an evening, night, weekend, and this needs to be recognized. And so we have after-hours premiums, which are going to be applied to the direct patient care rate. An additional $25 will be provided when you provide care between 6 p.m. and 11 p.m. on a weekday evening and between 8 a.m. and 11 p.m. on a weekend or statutory holiday. An additional $35 an hour is provided when you provide care between 11 p.m. and 8 a.m. on any day of the week, because I think we can all recognize providing care at noon versus providing care at midnight feels different for all. Now the interaction codes. This is where it gets a little fun. Now, this slide shows several of the interaction codes for inpatient care, long-term care, and palliative care facilities. These interaction codes were designed on the common workflows for each type of facility-based care. And so you won't be surprised to see that there are codes for admissions, regular visits, urgent assessments, procedures, discharges, end-of-life visits, and consultations. The maternity interaction codes are going to have a slightly different structure, which we're going to review in just a moment. Again, I want to stress the rural retention premium applies to all time and interaction codes, and they're going to apply to all services of LFP, both in the clinic and home visits, and into this new realm of facility-based care, which is what all our rural physicians deserve. On-call availability payments, returning to that, and something that all of us have been asking for many, many years. The fourth element of facility-based care under the LFP. The purpose of these payments is to recognize the challenges of providing care and availability for patients and facilities, often on those evenings, nights, and weekends. We know that having physicians available to provide this essential 24/7 care as part of a group is critically important in the functioning of hospitals, maternity wards, and long-term cares, regardless of whether a patient actually ends up being provided care on that particular night or evening or weekend. We also know that call groups are often comprised of family physicians who work under a variety of payment models for clinic-based care, as well as family physicians who do not provide clinic-based care. As a result, the on-call availability payments will be provided for family physicians working under a range of payment models, and it will not be limited to just those physicians who are under the LFP payment model for clinic-based care. The on-call availability payments will be funded and administered differently based on the facility setting. Physicians providing maternity care will receive an on-call availability payment through the Medical On-Call Availability Program, aka MOCAP. The on-call availability payments for inpatient care, long-term care will be funded and administered by FPSC. These new FPSC payments will link with the FPSC's current long-term care and inpatient initiatives and will be an evolution of these programs. As facility-based care billing gets started, an on-call availability payment for palliative care facilities will not be provided at this time. Work is ongoing to understand how physicians of different specialties work together to provide this essential care to our palliative care patients across a range of settings. Now we're going to talk about each setting in a little bit more detail and see how these elements work for each facility-based setting. Maternity care in hospital. As mentioned, maternity care billing has a different structure and weighting for time and interaction codes. Payment is going to be weighted more towards time to reflect the workflow and unpredictability of labor and birth care. You can consider this largely a time-based payment. As a result, the interaction codes are weighted less. And here, the main maternity interaction codes are going to range from $30 to $60. For care provided to a pregnant or postpartum patient and newborn patients, each unique patient is billed as an interaction. This is very exciting news to all of us who struggle to take care of newborns, and there was only one payment for multiple interactions. This includes urgent assessments, labor admissions, postpartum and newborn rounds, and discharge visits. Births are a separate interaction code and can be billed for a wide range of types of births, whether they're vaginal, vacuum forceps deliveries, or C-sections, or for those unfortunate deliveries that include antenatal losses. For those of you who provide consultative care, there is also a consultation code so that you can provide your expertise to your physician and midwife colleagues. Now let's move on to inpatient care and see how billing will work under the LFP payment model. You can see again some of the common interaction codes with rates ranging from $30 to $90. These rates were again chosen considering the average length of time required for different types of inpatient care visits. These visits include admission, visits, urgent assessment, procedures, discharge, or end-of-life visit. For those of you who provide consultative care again, there is a code to provide that. So you can provide your own wisdom and expertise to your colleagues. Long-term care facilities. This is a little snapshot into how long-term care facility billing will work under the LFP payment model. Again, you can see some of the common interaction codes with rates ranging from $25 to $90. These rates were chosen based on the average length of time required to provide these different types of long-term care. These interactions include admissions, visits, urgent assessments, procedures, discharge, and end-of-life visits. For those of you who provide consultative care in long-term care facilities, again, we've included a consultation code so that you can share your ideas and expertise to your colleagues. Palliative care facilities. We recognize that there's a lot of overlap with long-term care and palliative care, so you're going to see some similarities there. This is intentional because both types of care are end-of-life care, although with some significant clinical differences, and we want to recognize the similarities.
Thanks, Tahmeena, for sharing all that information with me. What we have shared with you in this presentation represents an important and significant health change that we believe will continue to move us forward towards empowering family physicians to provide accessible, high quality, comprehensive, and continuous care that is adaptive to the needs of their patients, to their communities, and ultimately to those who provide the care. As we move forward in this payment model, we'll be working together with divisions of family practice to realize the full potential of these system changes. We will be inviting divisions of family practice from all corners of the province to play a continual role in supporting facility-based care. They will be responsible for administrating the new on-call/availability payments and supporting physicians in helping to organize their call groups. We recognize many are doing this already, but it's a continued investment and acknowledgement how important the divisions of family practice are. They will continue to play a key role in recruiting and supporting physicians. They will continue to provide important feedback and information in helping us understand the impact of these changes and continuing to improve how we support physicians. By the end of February, but days away, we will be sharing more detailed information with you on the evolution of FBFC's current funding in facility-based care and how the new on-call or availability payments will be delivered. These changes to support FBFC supports were developed in lockstep with the development of LFP into facility-based care, and we commit to continue to work together to support these changes in communities and for physicians. We also invite you to do what you do best, which is amplify the voices of our physicians in your communities, helping organizations understand community needs and working with us to help address those needs. When will this start? Well, we're excited to announce that the LFP model for facility-based care will begin this June 2024. There's still a fair bit of work to be done before and then and now, but again, we commit to you on behalf of BC Family Doctors, the Doctors of BC, the Ministry of Health, and FBFC to ensure that this work is happening at a rapid pace. And so what needs to occur between now and the June launch for facility-based includes things like finalization of billing rules and codes, the creation of the new LFP payment schedule, a programming of MSP teleplan to ensure that it can accommodate the clinic-based, facility-based care codes on a single comprehensive model, and finally, to help you development of billing resources, education, and support for physicians. For more information, and again, we recognize this was a lot of information to take in the last 30 minutes. We thank you for taking the time to watch this recording. We appreciate the effort that you are making in your respective practices, your facilities, and your communities. And we expect that we will learn together how the LFP payment model will work in these 4 facility settings. As more information and resources become available, we will keep you informed through the LFP newsletter and by a series of other means. In the meantime, if you have any questions about this information on the recording, please reach out to fp.billing@doctorsofbc.ca. And for those of you who have not renewed your membership at Doctors of BC and BC Family Doctors, please do so. There's an opportunity to not only invest in the organization, but hopefully what the organization continues to do to serve you. Thank you for taking your time to watch the webinar this evening. Thank you for, again, the work that you're doing in your practices in your community. Have a great night, and we'll talk again soon.